This is the key point summary of the hormonal regulation concept and exemplars. Remember that hormones regulate in order to keep the body in homeostasis. This is primarily a function of the endocrine system. There are hormones that cause release of the hormones, and then hormones that change the functions of the organs or that are circulating in the body. The primary glands and organs that we discuss in our course are the pituitary gland, the adrenal glands, the thyroid, the parathyroid, and the pancreas. In this course, we do not focus on the reproductive hormones. The pituitary gland has hormones that are released from the anterior pituitary and hormones released from the posterior pituitary. For the purpose of this course, we are focusing on the antidiuretic hormone from the posterior pituitary. If there is not enough antidiuretic hormone, known as ADH, the kidneys are unable to reabsorb the fluid in the bloodstream, and the patient will have excessive urine output. Causes include head injury, tumors in the posterior pituitary, surgery of the pituitary gland, and other central nervous system causes. If unmanaged, the client will urinate out up to 20 liters of urine. This is more than the amount of circulating blood, so the client is at risk for profound hypovolemia. The serum osmolality will be high or concentrated, and the urine osmolality will be dilute. When we talk about nursing interventions, we always rattle off intake and output as one of our nursing interventions. In this case, it is vital that the nurse closely monitor the urine output for any patient with a head injury or a pituitary tumor. This means measuring the urine output hourly, including emptying the entire Foley bag every hour in order to properly assess the output. The patient will get additional IV fluids, but will also receive ADH hormone in the form of vasopressin, desmopressin, or DDAVP. Those are all the names of ADH hormones that we administer. It is usually given IV, but can be given in other forms. The nurse knows it has been effective when the urine output normalizes. So we don't want the patient to not have enough urine output. So we're looking for it to be in a normal range of urine output. If there's too much ADH, that is known as syndrome of inappropriate ADH, SIADH. This is caused by head injuries, a side effect of some medications, and there are many other causes of SIADH. In SIADH, the kidneys don't recognize that ADH is needed, so they hold on to the fluid. The patient has lower urine output, but their manifestations are hypervolemia. So they have hypervolemia without edema. They have crackles, an S3 heart sound, but do not have edema. The serum osmolality will be dilute or low, and the primary concern with SIADH is as the blood is dilute, the sodium is low, so hyponatremia. So the manifestations will also include those of hyponatremia, including nausea, vomiting, headache, abdominal pain, and more. Treatment depends on the sodium level and the patient's manifestations. The first line of treatment is to determine the cause, and maybe we need to stop the medication or whatever that is, and treat that. And the patient will be placed on a fluid restriction regardless of the severity. The more severe patient, will be treated with 3% sodium chloride, a hypertonic IV solution that will be given very slowly. Usually it's about 15 mLs per hour to replace the sodium. Hormones associated with the adrenal cortex are many, including mineralocorticoids, glucocorticoids, and androgens. Manifestations will reflect most of these hormones. One of the primary concerns is the hormone cortisol, which is sometimes known as the stress hormone as it responds to stress. Cortisol is controlled by the adenocorticotropic hormone, or ACTH. Not enough cortisol in the system leads to Addison's disease. Generally, Addison's is associated with having an autoimmune disorder. Manifestations include bronzing of the skin, fatigue, lethargy, and increased thirst. The concern is that the patient will go into Addisonian crisis, and the patient will need to keep an injection of hydrocortisone on hand and know how to self-inject it. The treatment for Addison's is hormone replacement. Too much cortisol in the system leads to Cushing's disease. Most often, this is caused by too much exposure to steroids, either by long-term use or overproduction of ACTH. Manifestations include the rounded face, or we sometimes refer to that as moon face, a hump between the shoulders, and they can have visible pink-purple stretch marks. The treatment is to manage the cause. If the cause is a pituitary tumor, the client may have surgery to remove it. This type of surgery is called transsphenoidal resection of the pituitary tumor, and the surgical approach is through the nares. The parathyroids are located on the thyroid gland. The parathyroid hormones help to control calcium in the blood, as well as phosphorus and vitamin D. Too much parathyroid hormone leads to hypercalcemia, and the manifestations are those of hypercalcemia, including muscle aches, cramping, twitches, positive Chvostek, and trousseaux. The causes include parathyroid tumors and others. The patient may need calcitonin to lower the calcium level. Not enough parathyroid hormone is not enough calcium, and the manifestations include tingling in fingers and more, brain fog, muscle cramps, and dysrhythmias. Causes include damage to the parathyroid glands, genetic conditions, and more. Treatment is to manage the calcium through supplements. The thyroid hormone is responsible for many metabolic functions such as energy, temperature, weight, and more. The thyroid is located in the neck. The thyroid releases T3 and T4 and is regulated by thyroid stimulating hormone, or TSH. Too much circulating hormones, T3 and T4, can lead to hypermetabolic state and hyperthyroidism. One of the primary causes is Graves' disease. Manifestations of hyperthyroidism include unexpected weight loss, irregular heart rate, sweating, and irritability. The patient may have a goiter present, and they may be treated with radioactive iodine, and sometimes they will have surgery. One of the medications used to treat hyperthyroidism is called methimazole. This takes about 6 weeks to lower the T4 levels. From a nursing perspective, if radioactive iodine is used, the client will need to follow special precautions at home, including using a separate bathroom or flushing the toilet 2 to 3 times, laundering clothes separately from their family, and more. If surgery is required, the patient will likely be on solution of saturated potassium iodine, or SSKI. This will help reduce the vascularity of the thyroid gland. SSKI is liquid and will stain the teeth, so the patient needs to be instructed to drink it through a straw. Remember that the location of the thyroid or goiter or surgery can affect the airway. The primary concern with hyperthyroidism is the patient will experience what we call thyroid storm. This is a surge of overproduction of circulating thyroid hormones. Think of all of the manifestations we just talked about and magnify them. Thyroid storm manifestations include high temperature, high heart rate, high blood pressure, pacing, anxiety, and more. It takes time for all antithyroid medications to work, so the patient's manifestations will need to be treated. So we'll treat them symptomatically while we're waiting for the systemic effects of their medications. The fever should be managed with antipyretics, and the blood pressure and heart rate will be managed with a beta blocker. The one they usually use is propranolol. Too little thyroid hormone is known as hypothyroidism. It occurs most often in older women. This is a slower metabolic state, so the manifestations are slower: constipation, fatigue, cold sensitivity, dry and brittle hair and nails, and unexplained weight gain. Because of the low circulating T3 and T4, the thyroid stimulation hormone will be high. Remember, the body's always trying to maintain homeostasis, so the stimulating hormone will increase to try to increase production of these hormones. Treatment is with hormone replacement, medications known as levothyroxine. It is given orally in the morning and on an empty stomach. Taking it on an empty stomach allows it to be absorbed properly without interacting with foods. The patient will generally not see a change in symptoms for a few weeks. If hypothyroidism is severe, it can lead to a disorder called myxedema coma. This is an exaggeration of the hypothyroid symptoms: severe cold intolerance, weakness, lethargy, or coma, swelling of the face, tongue, and legs. Myxedema coma can be caused by undiagnosed hypothyroidism or stress responses in somebody with a diagnosis, such as infections, trauma, surgery. The patient will be given levothyroxine IV. With hormonal disorders, it's a balancing act. Too much of a medication, such as levothyroxine, can lead to the opposite disorder. Type 1 diabetes mellitus is typically diagnosed in older children or early adolescents. The pancreas is not producing insulin. There is none. The patient will require an exogenous or external outside source of insulin. The patient has the classic signs of the 3 Ps: polyuria, polydipsia, polyphagia. They are generally thin and underweight, among other symptoms. Patient education includes learning to take their own blood glucose levels. These days, there are devices that continuously monitor the blood glucose and send alerts to the phone or watch. Evidence shows that keeping a background level of insulin helps to keep better control of the blood sugar, so they would likely be on a long-acting insulin, or one that doesn't have a peak level, to keep that background control. They will also be prescribed supplemental short or rapid-acting insulin to take before meals, and will need to be taught about calculating the amount of carbohydrates in the meal. Insulin pumps help to keep the type 1 diabetic's blood sugar under control. Stress or illness can cause a rise in the blood glucose, and a plan for what to do in times of illness should be reviewed with the client. One of the primary concerns is the development of diabetic ketoacidosis. This is a serious complication and can lead to coma and death. The patient has the classic symptoms of hyperglycemia, along with nausea, vomiting, shortness of breath, fruity breath, and Kussmaul respirations. Blood sugar will be very high, and the potassium level is affected by the dehydration. Blood gases reveal a metabolic acidosis. The treatment is IV fluid and IV insulin infusions. The potassium level will be watched closely, as when the fluid volume status is restored, the potassium should shift back into the cell, but they likely will have some potassium replaced as well. Type 2 diabetes mellitus typically affects the adult, generally older, overweight, or obese adults. In type 2 diabetes, the patient is still producing insulin. It is just not responding appropriately to the glucose levels, or it doesn't enter the tissues. Sometimes this is referred to as insulin resistant. Manifestations are those of hyperglycemia. Management is through oral anti-diabetic medications such as metformin or glipizide, or through non-insulin injectables such as Victoza and Ozempic. Remember, one of the concerns with metformin is that the medication should be held for 2 days before and 2 days after a radiology exam using contrast, as the contrast is nephrotoxic, and with metformin can lead to acute renal failure. A major concern with type 2 diabetes is the development of hyperosmolar hyperglycemic syndrome. This is a life threatening disorder of uncontrolled blood sugar in the type 2 patient. The patient's symptoms are those of hyperglycemia with lethargia and possible coma. The treatment is the same as for DKA with fluid boluses and IV insulin. Once the blood sugar is under 250, the care will switch to subcutaneous insulin and the client will be taken off of the IV insulin. All diabetic patients need to be taught about manifestations of hypo and hyperglycemia, how to take their medications, and how and when to check their blood glucose. Blood sugar control is measured by hemoglobin A1C, which is an estimate of blood sugar levels over the previous 6 to 8 weeks. Complications of diabetes include both macro and microvascular problems. The high glucose environment leads to destruction or distortion of the nerve endings and the capillaries. Macrovascular complications include those of large blood vessels and our peripheral vascular disease, where there is poor venous return from the peripheral blood vessels to the heart, and this can lead to the development of venous stasis ulcers on the calves. Other macrovascular complications include higher risks for development of stroke or heart attack. Microvascular complications are due to the effects of high blood sugars on the capillaries and affect the small blood vessels. Microvascular complications include retinopathy, nephropathy, and neuropathy. The diabetic patient should have an annual eye exam and see a podiatrist annually to evaluate for retinopathy with the eye exam and neuropathy with the podiatrist. The endocrinologist will monitor renal function at least annually for presence of kidney disease. Foot care is an important part of care for a client with diabetes, as the potential is there for neuropathy. Neuropathy. The client must receive diligent foot care and be seen at least annually by a podiatrist. The last concept in hormonal regulation is obesity. Obesity is a medical condition that presents many challenges, as the client is at risk for developing many complications and comorbidities. Clients are encouraged to modify their diet and activity. Overall, there's a low percentage of people who are able to keep their weight off through diet and exercise, and there are surgical options including lap banding and gastric bypass surgery, or Row-N-Y is the other name we call that. That reduces the stomach size so smaller portions are all the patient can consume. These surgeries also come with constant complications, primarily those of post-op complications. This is the end of the summary of hormonal regulation.